Oh, thank you so much for joining us. I know people are still popping into the room. We're thrilled to have you all here with us today. My name is Emmy Betts, and I'm here with Ashley Brooks Russell. I serve as the Deputy Director for the Injury and Violence Prevention Center here at the University of Colorado Anschutz Medical Campus. Today's presentation is part of our monthly Research to Practice webinar series, where we present topics in injury and violence prevention. Before I get to our fantastic speakers, I have a few logistics. So the session is being recorded, and we will send out the video link to everyone who registered. You can also find past webinars online, and we'll put that link in the chat box. Please put any questions you might have for our presenters into the Q&A box. They've designed their presentation to have time at the end for plenty of discussion, and we welcome your questions, comments, ideas. And then please join us for our next webinars. This year, they're all on the second Tuesday of each month at noon Mountain Time. Next month, we'll be talking about climate change and workplace injury. Then November, we'll be looking at pre-hospital care and injury prevention in the military. And now for today, I'm so excited about our speakers today. Our session is titled Advancing Athlete Health. It's a team effort. We'll be using concussion as an example to talk about the study of athlete health and well-being from the perspective of both public health and health services research, as well as the perspectives of a former athlete and a current clinician in training. So our first speaker is Dr. Christine Baugh, who is an assistant professor at the Center for Bioethics and Humanities and the Division of General Internal Medicine at the University of Colorado. Christine conducts interdisciplinary research at the intersection of health, policy, sports, and ethics. Much of her work has focused on the acute and chronic health implications of repetitive brain injury from sport and the resultant individual, institutional, policy, and ethical considerations. We are lucky to have her here on campus. Her work has been featured by lots of leading media outlets like the New York Times, the Washington Post, ESPN, and Sports Illustrated. And she was named to the Forbes 30 Under 30 list in sports. And today she is joined by David Bruton Jr. David is a former professional football player in the NFL, having spent 7 years with the Denver Broncos and 1 with the Washington football team. He also played football previous to the NFL with the University of Notre Dame, where he graduated with degrees in political science and sociology. And he's now also on campus as a student of physical therapy at the University of Colorado Anschutz Medical Campus with a plan to graduate this December. He is a member of the CU Physical Therapy Scholarship Board. He's the founder of Bruton's books. And in 2015, he was a Walter Payton NFL Man of the Year award winner. He's an advocate for change, and we are thrilled to have him here today. And with that, I will turn it over to our presenters. Thank you.
Thank you so much, Emmy, for that lovely introduction. I'm going to share my screen, but I first just want to say thank you to the Colorado Injury Prevention Center, and congratulations on reaching center status at the university. It's such a huge boon for our campus to have this interdisciplinary research center where folks interested in all injury and violence work can come together collaboratively. I also just want to say thanks to David, who we presented last year on a panel together, and I must not have scared him off. He said yes when I asked him to come join me today, and I'm looking forward to a fun presentation together if it's anything like last year's was. So as I share my screen, we will get started with our presentation, again titled Improving Athlete Health. It's a team effort. And I just want to begin with a bit of a question for you, a thought puzzle for our audience who's here today, and even the folks who are on the screen with me. When we talk about the title of our talk, Improving Athlete Health, it's a team effort, what comes to mind for you? Who is a part of that team? What are their roles or responsibilities? What impact on athlete health might they have? What are the tools that are part of the toolkit for improving athlete health or maintaining athlete well-being? And just pause and think about what that picture looks like for you, because my goal is to perhaps expand that picture a little bit using the frames of public health and health services research and some overarching pictures of what that looks like for injury prevention broadly and athlete health specifically. So we're on the same page about what I mean when I speak about injury prevention, and we're going to talk a lot about concussion today, but this applies more broadly. The spectrum of injury prevention really is quite broad, and in typical public health framing, there's what most people think of as prevention. We call that primary prevention. This is preventing the injury from occurring in the first place. So what can we do to prevent a concussion from occurring, for example? But in public health, we also think about other levels of prevention. So for example, secondary prevention, which more or less means trying to detect the injury early or prevent it from getting worse. So in the space of concussion, how do we make that fast diagnosis? How do we quickly move toward evaluation and management? And then we also think about tertiary prevention. So this is more about trying to improve the quality of life or reduce the symptoms, the total burden of the injury once it has occurred. So this is maybe following best practices in concussion management, using an interdisciplinary team to reduce the symptoms or the duration of those symptoms. So I just want to pause. I know this framing may be a bit new, but David, I'm curious, in your experience when you were an athlete, did you see efforts or interventions across this spectrum come up? Was this something that was internalized for you, or your sports med folks would be preaching about in any way? Kind of what has your experience been with injury prevention anywhere or across that spectrum?
As an athlete, we did a lot that was geared towards injury prevention. I think a lot of our focus with our strength conditioning coaches and things of that nature were based on primary interventions. And then when you seen that primary preventions, and when after an individual had an injury, they tried to address any of these imbalances that may have led to that injury. So we did see a lot of different levels of this prevention that you're speaking on. However, with concussions, there was a change as far as how the NFL managed a concussion, with different healthcare professionals being involved, different pre-concussion tests, post-concussion tests. There's been a lot of changes because there has been a lot of noise about CTE and surrounding concussions, and that concern that parents and athletes both share.
And you were mentioning strength and conditioning, like what kinds of folks were involved with these sorts of efforts in your experience as an athlete?
As far as strength conditioning coaches, as well as the athletic trainers, the PTs, and every athletic trainer, every PT, every strength conditioning coach has their own train of thought, their own school of thought. So I had one strength conditioning coach was built based on power and lifting heavy, power cleans, heavy bench, heavy squat. And then we had our second strength conditioning coach who came in after was based on functional movement, which was more towards that injury prevention. If we moved better, our movement was a lot cleaner, we would see a decrease in injuries, which we did as far as like hamstring pulls, quad pulls, calves, and things of that nature.
Yeah, that's really interesting. And I think, I don't want to make any assumptions, but I think a lot of us, when we first think about that question that I posed about the team, who's involved in this team effort to prevent athlete injury, we probably primarily think about folks like those you just mentioned, right? These clinicians, strength and conditioning coaches, probably the athlete themselves, right, being involved in this spectrum. Is that kind of who came up for you when you were thinking about that initial question?
Oh, absolutely. Especially throughout my time in the program, I realized there's a lot of hats that are involved in just management of an injury, not only isolated to concussions. And a big thing that I'm seeing here, even in my clinical experience now, is just the communication that has to be had between these different healthcare providers. So making sure everybody's on the same page, as well as the athlete, or if it's a youth athlete, the parent as well. So the medical management team has to remember that we're focused on the patient, and then we have to realize that our lines are going to cross, and we have to be able to be on the same page to get this athlete to return to sport and prevent any further injury.
Yeah, that's amazing. It's really fun to see how your perspective as a budding clinician is kind of intersecting with your experience as an athlete. In health policy, we think a lot about that kind of topic that you just mentioned. We call it coordination of care, right? How
Mhm.
multiple clinicians have to be involved in this, interdisciplinary effort to help an athlete who is injured. So it's really interesting to hear about that experience. I'm going to tell a little story, which I think shifted my perspective on who this team might be. And I'll be curious as I move forward. I'm going to pose this question again and again, both, to you, David, but also to our audience, how this story and perhaps some of the framing that I bring forward might shift or expand who we think of as part of this team. So I think it was about 2012, 2013, I was conducting a survey-based research study of college football players, trying to understand more about their perspectives on concussion, on injury more broadly, their behaviors around concussion reporting, what might facilitate a rapid report, or what might be a barrier to that, what their attitudes and perceptions were about things in their environment. So I was flying around the country with like a suitcase full of paper that I would hand out, and folks would fill it out, and I'd come back home and I'd type it all into my computer. And really the heart of that effort, in addition to the athletes, were these athletic trainers who helped facilitate the process, got the guys in the room, were clearly on board with learning and improving concussion reporting in athletes. And one of the schools that I went to has stuck with me ever since. It's almost been 10 years now, which makes me feel a little old, but it is true. There was one athletic trainer at this Division I, it was FCS, but Division I school had one athletic trainer for not just the football team, but for the entire student athlete population. And yet he spent the extra time to have me in. He clearly cared a whole ton about his athletes. He did the very best that he could. But, in chatting with him, as, before and after the survey was administered, you could just tell that there's no possibility for him to fully realize his potential as a clinician, given the constraints that he faced, the number of athletes he needed to see, the teams he would travel with and leave other athletes behind. And, I know we're in a phase of time where we're talking about burnout a lot, but it was a thing that he was really feeling at the time, because he was unable to live up to the full potential of his degree, of his desire to help people. He was feeling really hamstrung. And so that stuck with me, and it kind of rattled around my brain for a little while, and I didn't know what to make of it. I finished out that athlete concussion reporting study. It was, successful and informative in its own right, but this person's experience just really stuck with me. And it wasn't until a bit later, when I was finishing up my public health training, that I started to understand more about these levels of influence, right? This environment that the clinician himself was working in provided these constraints that he couldn't escape, right? The athletes also couldn't escape. It might be something like what folks would call social determinants of health, these environmental factors that are in many ways beyond our control, not beyond everyone's control, but beyond, often the individuals who are living through them's control, and can really have meaningful impacts. And so in public health, one of the frameworks we have for understanding this, and this is a paper that applied it to concussion specifically, or athlete injury specifically, with some of my colleagues at other institutions, including University of North Carolina, was to think about these multiple levels. This is called the social ecological framework. We've got the individual level, right? This is the athletes that we're typically talking about in the concussion frame. We've got the interpersonal stuff, right? That's kind of where we got to in our first wave of answering that who's part of the team question, right? It's this relationship between the athletes and the clinicians, or the athletes and the strength and conditioning staff, the communication between those folks, pressures that might arise, and those kinds of factors. But beyond that, there are these bigger pieces. There are these what are typically framed as community and policy pieces that kind of constrain sometimes, or could facilitate in the right set of circumstances, everything that happens within those personal and interpersonal relationships. And thinking through, this one person taking care of so many athletes at a single institution, that was a situation that arose based on a university level decision about funding, based on a community level decision about priorities. And so having this frame had been really helpful for me to kind of think through these broader levels that can still affect individual athletes. And in a similar kind of frame, in health policy, we tend to think about this thing called a learning health system. It's how do you iteratively improve healthcare using evidence and clinical relationships to move closer and closer towards, high quality care. And here in a kind of multi-level framing of that idea, we have similar kind of levels, right? We've got the individual, we've got the team, but then we move up from there and we're getting into the athletic department, we're getting into the university or the maybe the club in the professional setting. We're getting into the macro system, things like the NFL or NCAA, National Football High School Athletic Association, right? And all of those groups or bodies or institutions have some kind of say over what happens below. Sometimes that can be helpful, right? We have concussion policies, David, you mentioned, kind of came into play while you were in the NFL. That's a big kind of macro thing that wasn't something your athletic trainer did on their own necessarily. Of course, they were involved, right? But it was probably a league level policy that came down. And so thinking through kind of these levels of influence and that full spectrum of primary, secondary, and tertiary prevention, I'm coming back to my initial question and hoping it's a little leading right at this point. Like I want everybody to think a little bit more about, are there folks somewhat beyond the people who initially came to mind that should be considered part of that team, right? What roles might they have, these policymakers or these club owners, the coaches, the university presidents? And as we think about the tools in our toolkit to work towards athlete health, how can we move towards including things that may not have initially come to mind, right? Preventative exercises are awesome. Rehabilitative exercises are awesome, very necessary. But is there anything we can do at those broader levels of influence, perhaps policy, for example, to think more towards that primary prevention side? I'm going to stop talking. David, I'm just curious as to your reaction, now that I've spieled on for a little while here, what do you think?
It's great that you put up that framework. And I'm just looking back to when I broke my leg the year of Super Bowl 50, and just knowing that, how tough it was for me emotionally, psychologically, that I would not be able to be out there with my teammates, the guys that I went out there and practiced with. We hung out, like we were like a family, and that pressure there to not be out there on the field, it is a driving force. It is very influential as far as whether or not I'm gonna try to play, maybe I should sit out, things of that nature. Also, just thinking about the policies that are involved in this preventative care, just thinking about our healthcare system here in the United States. Insurance is not necessarily willing to pay for preventative care. Like it has to be secondary prevention or tertiary prevention for the insurance companies to even look at potentially paying for it. So now our prices in clinic or anything that's potentially prevention based is, out of pocket. Not everybody can afford out of pocket, or they can afford one session at a time. So are they really getting that preventative care that they need, that primary prevention?
I bet you see that a lot in your budding physical therapy career. I mean, physical therapy feels to me like it could run that full spectrum, but somehow gets relegated towards the secondary and tertiary.
Absolutely, and at times it feels like it could be potentially too late, or you sit back as a therapist and you're like, wow, if we could have addressed this muscular imbalance, maybe this pitcher would not have had this UCL injury, because we would have been able to work on the shoulder and the thoracic spine, so they weren't having to put all that torque through that UCL ligament of the elbow. Yeah, I've seen it quite a bit throughout my time. I didn't know how prevalent it was because I was under this umbrella, that macro umbrella of like, well, I have an athletic training staff right there. I have some of the top strength conditioning staff members out there with some of the best well-rounded education that you can have in this grade A experience. But when you get out into the real world, not everybody has that access. Not everybody has that luxury. Not everybody has the money to afford to get preventative care. So yeah, we're kind of shackled by the policies, and you know, that's I would think that's probably one of the biggest stakeholders as far as primary prevention.
Yeah, when you were playing, I'm not sure if it would have been when you were in college or in the NFL. You know, there were some major shifts in concussion policy.
Mm-hmm.
Was that something you realized as an athlete, or you know, was that something that was like really right at the forefront of your attention? Did it meaningfully change your experience? You know, how did that macro level thing kind of affect your day-to-day, if it did at all?
You know, as I look back at it, when I was applying for PT school, I started to realize it a lot more, the changes. Later on down my career, as a young athlete, I'm just trying to make the club. You know, you can't make the club in the tub. All these things are going through my mind. But as I got a little older, became a veteran, you start seeing these changes, these subtle changes. Where my first couple of years, we didn't have a PT on staff. The NFL mandates that there's a physical therapist on staff now. Now you get your bell rung. Nowadays you get your bell rung, and if upstairs or New York sees that you're potentially could have had a concussion, they'll pull you off the field and not wait for the athletic training staff. Versus early on in my career, you pretty much would have to be on the ground, or you'd have to take it upon yourself to report that you're not feeling well. But now it's the people upstairs or in New York that are pulling that individual off the field. So there's definitely been quite a few changes. Even just the plan of care with concussions have changed throughout the NFL, or just in general, just because of our understanding of, you know, maybe resting in a dark room for 5 days isn't the best. Maybe 1-2 days, but let's start doing some sub-maximal threshold aerobic activity. Let's start integrating some of these football or soccer or tennis-like activities to the point of some symptoms, but let's not overdo it. And I think there's just a better understanding of how to address it. And that's why we're seeing some of these changes in the collegiate level, the professional level, the high school level, things of that nature.
Yeah, no, I totally agree. I mean, there's been both a rapid policy, as rapid as policy gets, right? But a pretty significant policy change across many levels, as well as these clinical changes, based largely on, you know, research that's happened over the past, you know, 5 or 10 years. I'm going to kind of transition once again and go through a couple of research examples. And I just want folks to kind of keep in mind this overarching spectrum, both of prevention, primary, secondary, tertiary, but also this kind of levels of influence framework as I go through the examples. And we're going to kind of talk through together where those examples fit. And, you know, in the end of this presentation, my hope is that we all have a little bit better understanding, or maybe not better, maybe different understanding about how these different levels of influence can impact athlete health, and maybe where our biggest changes can come from, right? And so just keeping that in mind as we move forward with a few examples. So this is a research study that I did, published in 2019, Journal of Neurotrauma. And one of the questions I was trying to understand, again, thinking more primarily about this injury reporting phenomenon, is, you know, what are factors that might help or hinder athletes' injury reporting capabilities or willingness? And this was, again, in football. So it was about, let's see, maybe 5 football teams, just under 300 athletes participated. It was a survey-based research study. This was Division I FBS schools. And what we found, kind of the main highlight findings, were that athletes were less likely to report concussions as well as injuries as they had experienced more of them. So from your first to your second concussion, you went from some willingness to some lesser willingness. From your first to second injury, you went from some willingness to some lesser willingness. We didn't have an understanding of the whys behind that, right? It was just sort of an association level finding. We also found that on average, athletes were much less willing to report a concussion compared to another injury. So on average, athletes reported just under half of their concussions is what they told us as researchers, whereas they reported much more than half, about 80% of their other injuries, shoulders, knees, ankles, bruises, lacerations, right? All of these kinds of things that can happen. The other interesting thing was that no athlete reported more than 4 concussions to their medical providers in their football career. So despite them writing down on our survey that, some of them had suspected that they had sustained, upwards 5, 6, 7, 8, 9, right? That's their personal estimation, having played football for about 10 total years on average. None of them had reported more than 4 in total to their medical provider. And so that was kind of interesting and aligned with this colloquialism about what clinicians thought about the number of concussions somebody should have before they should consider maybe not playing football anymore, right? Sort of this environmental constraint in some ways on the athletes reporting. I'm gonna just say that this is, primarily an individual study. This is an individual's perceptions or willingness about whether or not to report their injury. And it's really a secondary prevention study. But David, I'm curious, if you have any reactions to those, initial findings. Is that something that feels like it resonated with your experience while you were playing, or things you saw from your teammates?
Absolutely. And even with my oldest son, you see it all the time. Kids aren't necessarily willing to report an injuries just because they want to keep playing, right? And then specifically with football, it's kind of the culture, to be macho, to be ultra tough, not to, show weakness or pain as weakness, leaving the body type macho or what have you. So yeah, that definitely resonated with me, and I'm not shocked by it, honestly. I'm not shocked that only there's athletes who rarely report a concussion, or there's less than 4 that are actually reported. I'm pretty sure I've even had more than the reported 6 that I've had, the 1 from college and the 5 in the league. I'm pretty sure that there's definitely been a few more times that I've had my bell rung. So that's very interesting as far as reporting, the injury reporting, for sure.
Is it, do you feel like concussion is taken differently in terms of willingness to report versus other, maybe let's say orthopedic type injuries?
And I think this is probably just going to be the student coming out of me. It's and what I've been exposed to at CU is the trust within the healthcare provider. Do you trust this individual to diagnose you with a concussion? Because they're not in your head. They're not seeing, a broken ankle or broken leg or anything. They're literally just testing you to see if you have a concussion. But you're just feeling a little foggy or have a slight headache. And you're over here trying to trust an individual who's not in your head. It's kind of hard. And then there's also the health literacy part of it. Are you educated enough to know, what a concussion could potentially feel like? Or are you well in tune with your own body to know that you don't feel right? There's so many things, so many boxes that have to be checked for an individual to trust a clinician, to trust what they're feeling, to to be willing to sit out not just 1 game, but a week, 2 weeks. There's pressure from collegiate ball, high school ball, to try to get drafted, to try to get a scholarship. There's a lot of pressure on kids or individuals behind just an injury.
Yeah, I think that some of my upcoming examples might tie right into some of those things that you said, which is kind of interesting. And I swear we didn't coordinate his talk with the talk in advance. I'm going to go on to the next one. So this was a study that we did. This was earlier, about 2015. So the NCAA at this point had put into place a rule that all of its member schools, so many of these colleges and universities, needed to have a concussion management policy, and that policy had to have a couple of different components, including annual athlete education about concussions. They required athletes to acknowledge their responsibility to report these injuries, and that if there was a suspected concussion, that an athlete would be removed from play and couldn't be returned until they got cleared by a medical professional. And so, we found in this study that there was, and this was just a few years after the policy had been implemented, even policy is an imperfect tool that relies upon a lot of folks kind of down the pike to implement the policy as it's intended to the full audience it's intended to follow through on. And there are better and more or less effective ways, I should say, at doing that. And so what we found was, while nearly universally our respondents, these were kind of sports medicine clinicians at a NCAA institution, we got pretty good representation here. Nearly all of them had a policy, but when you start to dig into it, those individual components were not always there, or they were there, but even the folks who helped put this policy in place were like, we could probably do better about this athlete education piece. We could probably do a little bit better in making sure we've got the sufficient medical staffing to really fully realize these pulling folks out and returning them safely. And so it's kind of interesting that even though this should be this macro level NCAA, kind of one of the biggest tools we have in the toolkit, it still relies on a lot of things underneath that umbrella in order for it to be really effective. And this particular policy was really focused on this secondary and tertiary prevention piece, right? If we think about what's included, education, that's not going to stop a concussion, right? Acknowledgement, removal, and clearance before return. This is all kind of post-injury in the spectrum of prevention. David, I think you were in college at the time that, right around the time that this was here, or maybe it was just after, I'm not exactly sure. Was this, I guess, in your experience, have you seen these policies or practices implemented kind of differentially across teams you've been at? Or I know you mentioned some folks in strength and conditioning just have different philosophies, but does this kind of follow the same idea, or have you experienced anything in that realm?
I think my experience has followed the same idea. These policies, these changes within the school as well as at the league level are secondary and tertiary prevention. I feel like the only thing that's primary prevention would be the changes in the helmet. It's a violent game, but even then, in some cases, that's seen as secondary as well. You have an injury, let's change the helmet. Now hopefully that helmet's further preventing any further concussions. It's for a concussion, I just see that it's so hard to have a primary prevention for it. And then maybe I'm just a little.
Yeah, I mean, I could have provided a slightly different policy example. I thought this one was interesting because of how differently it was implemented. I mean, we have seen, for example, the Ivy League, I think was initial, but after them, others have followed in really kind of significantly reducing the contact allowed during practices, for example, and have seen kind of resultant primary prevention changes in the number or rates of diagnosed concussion there. So there are like policy approaches in that sense. But again, it does rely on everybody below really following suit and being honest, not just to the letter of the law or the policy, but really to the spirit of it as well,
Now, I'm curious, Christine. I know, because I remember our contact practices were once a week until we got to week 12. And then it was like, once you got to week 12 in the league, you only had 3 contact practices until week 16. I'm just curious, have you seen a reduction in the number of concussions? Because I was just under the impression that the high rate of concussions were game day.
Yeah, so you're right that the highest rate of concussions is on game day. That's totally true. Interestingly, the NFL has been having a kind of a lower level of contact during practices. You were just saying this kind of once a week for much longer than college and high school for that matter. And unfortunately, like even younger than high school.
Yeah.
We're having like peewee kids, high school kids, college young adults have much more significant volume of contact during practice than these NFL clubs have been doing for quite some time. I think that's shifting. I mean, it's not perfect, but so I would say I am not aware of an NFL level shift just because they've been doing this for much longer. But in other contexts, these kind of I won't say less competitive, but pre-NFL levels of football, where we have seen those meaningful reductions in contact, reductions in the overall incidence of concussion has gone down. You're right, per competition or per day, the highest rate happen in competition. But if you can eliminate those contact days, one, because maybe they're not necessary to learn, or they're not as necessary, two, because you can just cut out that exposure, right? That repetitive head impact kind of exposure, even if it's not concussion. We think of that as kind of one of the big primary prevention tools in that policy level toolbox.
Yeah, and just thinking about also at the higher level, maybe you don't need that much contact. Maybe you don't need the run tackling drills. Now we look back to the youth athletes, the youth football players, the middle schoolers, the high school, who haven't been practicing that long, who haven't been tackling that long. And you're trying to teach heads up tackling and trying to keep them safe in that regard. I just feel like there's just two schools of thought there where, let's reduce it, the amount of contact days, but then we're losing the actual practice of form tackling to try to keep them safe, or we practice form tackling, but now we're increasing the risk in case it's not clicking for that athlete, and potentially having more collisions equaling more concussions. Like it just seems like concussion is just a tough topic to discuss and try to find an end all be all type of policy or plan or anything like that. It's so fascinating, but so tough and worrisome as a parent.
Yeah, I bet. I can only imagine. I'm going to go to the next example just because it really touches on one of these topics you brought up earlier, this idea of trust. So what we found in this study, again, a survey-based research study with college football players, we were asked them some questions about their perceptions of the conflicts of interest of their clinician, their trust in their clinician, and then how that associated with their willingness to report concussion or pull themselves out of a game and disclose a concussion specifically. And we found, David, that just as you mentioned, right, this idea of trust in your clinician was hugely important. And conversely, the idea that your clinician might be thinking about something other than your well-being, in addition to maybe your well-being, right, thinking about the coach or the club or keeping their job or whatever else that consideration that's not health might be, really also influenced, in that case, negatively an athlete's willingness to engage in a health-seeking behavior. I don't think it's going to be, that sounds like it's no surprise to you. You already kind of brought that up, is that, I know you mentioned trust. Was that idea, I'm calling it conflict of interest, but that idea that there's more than your health being considered ever something that came up while you were playing?
Absolutely. And I just could think back to numerous guys and myself looking for a second opinion because maybe you're not trusting what your primary athletic trainer or PT or whomever is in the department or the key stakeholders. You're not necessarily trusting them. So you want somebody who's not biased by a paycheck or biased by the club that they're working with. It's not surprising to me that you see this lack of trust more so there's phone in the office, but it's not surprising that you've noted that minority athletes have a perceived conflict of trust with these professionals. especially just look at where a lot of these athletes are coming from. Some of these minority athletes are coming from, like where there's a lot of health disparity, where there's a lot of social determinants of health that they have to battle day in and day out. Their parents are working 3-4 jobs, or they have this, they feel they're a little jaded because of things that happened in the past in American history, you know, things, even though it might not have directly affected them, some way, somehow that hits home. So there's just, there's no surprise that there's this trust and conflict of interest there. And then on top of that, it's like, well, I'm gonna trust myself, trust my parents more so than y'all, even though you had that education, that higher level, because what the medical profession has done to my ethnic background.
Yeah. I mean, that it seems to me to be a very reasonable and also challenging, position to be in. And I really like hear everything you're saying there. And it's interesting, again, just, as a researcher, we have these, at least as a more of a quantitative social science researcher, we find these kind of relationships, but to hear the stories behind them, right? To hear somebody who's experienced something that is in line with that finding is really interesting, and kind of reaffirms the value in both the personal perspective as well as the kind of quantifying this from a scientific one. I'm going to skip the fourth example just because I think 5 gets very close to it, and I want to make sure we have enough time for discussion. So example 5 was a study where we combined a bunch of different data sources. We were looking at an injury epidemiology data source combined with some information about how schools staff their sports medicine departments. We're trying to understand more about, does the number or types of clinicians on staff and or the organizational model, meaning who does a clinician report to ultimately? Is it an athletic director, or is it somebody at the University Health Services, for example? Who are they paid by? Is it the athletic department, or is it University Health Services? So do the numbers of clinicians, their organizational model, affect athlete injuries, whether it's types, rates, recurrence, severity? We asked about concussion specifically. So this idea, kind of coming back full circle to my story about this one clinician, I know he couldn't do his job as well as he wanted to. Does this trend hold more broadly? If we have, a very low number of clinicians taking care of a very big number of athletes, what do we see? And this was a study that was, again, powered by a data source called the Daedalus Center for Injury Prevention. They housed the NCAA injury surveillance program. So we had 25 sports at 141 schools over 5 academic years. It was about 12,000 athletes and 25,000 injuries, 3.5 million games and practices. This is a big data set, right? And across that data set, we found a very robust relationship between these structural features, this is college, right, of the college sports medicine environment. When I say structural features, I mean those things like the relative number of healthcare professionals to athletes. So we might call that in health policy kind of a caseload or a patient load, right? As well as this, what might be considered a structural conflict of interest, right? The idea of being employed by or paid by the athletics department versus a university health service. Both of those things were strongly associated with a variety of athlete injury outcomes. And in the ways that we might expect. So at schools where athletes had this greater access to healthcare providers, we were finding lower incidence of injury, re-injury, and concussion specifically. At schools where the sports medicine team was housed by or paid by the athletics department, we found that there were higher incidence of injury. So that's sort of like, do I trust my clinician? Do they have a conflict kind of idea coming into play? And interestingly here, when we think back to this overarching model that I put forward, if we're trying to pin down where this overarching research question fits, it's kind of hard, or at least it is for me. Maybe there's somebody smarter on the audience who would have a clearer answer to this. But for me, this is clearly not an individual question, right? We're not asking about individual much of anything, but there's features about this that are related to the team or unit, right? This is something about the sports medicine group. There are features that go a little higher than that. You know, that's a decision maybe by an athletic director to live in that model, or a sports medicine director to live in that model. That is a decision from the school about how much of their budget they're willing to put towards, you know, health and safety things like having sufficient clinicians. And then the fact that it's allowed to be the case that at least there's one school, you know, in my experience, that has kind of, in my perspective, a very unsafe ratio of clinicians to athletes. And it's not just one based on this more robust study. You know, that's a bigger problem. That's a problem that could be, you know, regulated away to some extent, at least, by these either macro levels or, you know, even the operating environment. The division could say something about what that needs to look like, or the conference. So it feels like it touches on a lot of things. And in the same way, it kind of touches across the range of the prevention spectrum. Where does this fit? Is this relationship because we're not doing as much primary prevention work if there aren't as many clinicians? The clinicians can't coordinate with maybe strength and conditioning, and so they don't have as much of that primary prevention. Is it some steps in that diagnosis pathway? Is it some steps in that tertiary prevention around, you know, being able to do the right management, which might be more intensive and require more clinician time? And if you just don't have those folks on staff, maybe you can't do that. And so I guess just coming back to, you know, what I see as this really big overarching question I keep kind of honing in on is, who is the team? What are their roles? What people or groups might be able to have the greatest impact here? And I think I'm just going to kind of close there with that overarching question for folks, because, you know, I definitely have a perspective on it. I'm sure you can tell it by now. But I think everybody has a role in some ways. Everybody who can come to mind in this spectrum, including, you know, folks who sit in the seats and watch the games, sometimes can play a role in what they're willing to put their dollars towards, and those sorts of things. So, you know, I'm just going to leave this question out here as kind of my final parting words, and I'm going to let David have the last word before we close for questions. You know, who should be part of this team? What should our toolkit look like? And which of those tools or people or groups can really be the most impactful?
Oh, just want to put the pressure on me to close it, huh? Jeez.
You could pass. We could go straight to questions. I'm sure we've got some.
No, I think, like I said earlier, concussion is such a dynamic topic, and such a topic that involves so many hands, so many hats. And to your point that you just brought up, money is definitely a big part. You know, bigger schools can afford more clinicians, but bigger schools don't necessarily want to spend that money on clinicians. They have other things they want to spend it on. So it's just great that you highlighted the fact that there are so many levels to a plan of care, to primary prevention, to tertiary prevention, and everything in between. And that's something that a lot of people need to know. I feel like the better educated people are as far as who should be involved or who could be involved in rehab, or concussion prevention, or injury prevention for that matter, we would see a decrease in the amount of injuries, a decrease of the amount of re-injuries, and potentially at the end of the day, more money being saved because we're not spending it on this tertiary prevention or any type of surgery. So if we want to talk about Moneyball, let's talk about money in the long run versus, you know, right here, right now.
Yeah, that's a great perspective. I think like that's the perfect thing to close on, the short perspective versus the long perspective, and which one really matters. I'm going to stop sharing my screen, and we'll move right into questions. I think we probably have some already, but Emmy, why don't you lead us away?
Wow. Thank you, you guys. Such an interesting discussion. And we have a lot of questions. I apologize ahead of time to people if we don't get to your questions. I'm going to try to kind of put some of them together. So first question to Christine. There's a question about sort of cultural change and around messaging, and I think this is really an interesting one. So she comments that, one thing she heard today and has heard in previous things of the words that we use around things like having your bell rung or tweaking your ankle instead of spraining your ankle and things. And I'm curious, Christine, do you see any motion on sort of a higher level to have us use more precise language as a way to respect this potential seriousness of injuries?
Yeah, I do. And I think that has been an effort across a range of stakeholders, obviously clinicians, and trying to emphasize that with the athletes. I know there've been efforts with folks like in the sports media, right? Trying not to glorify these brain injuries, trying to use the language that makes it clear that this is a brain injury. So I think this question is spot on. This is one of many ways, right? Again, levels of influence, right? This idea of being clear, precise, and honest about the nature and severity, potential severity of these injuries is really, really important.
Next question, David, is for you. We've had a couple touching on the same really tough topic, I think, of sort of sports below the professional level. So you guys did a great job, I think, talking about sort of larger schools or programs where you hopefully have all the resources that you really need. But when we think about kids, or we think about, even sort of high school, what the big gaps there are. And someone said, it might even suggest it's unethical to allow football to be played, at least among young players, say in junior high or in high school, if they're really at risk of injury. Thoughts on that, and in particular, how you either justify the level of risk or what you would really like to see happen to make the sport safer.
One, I love the game of football. It did wonders for me, so I'm a little biased there. But also as a parent, I did not want my youngest kid playing, my oldest kid now, God, he's 15 now, wow. I did not want him to play football at such a young age. I started around 7th grade. Ideally, that's when I would have wanted him to start, but he wanted to start a lot younger. I think there are a lot of things that could be in place. I know, like, coaches at certain schools, at actual schools, get a concussion education, but I don't necessarily think that you see that a lot at these club sports, and there's a limitation there. And then also parents have to be educated. They have to be well aware of like any changes in your child's mannerisms, whether that's during the game or even after, and be willing to pull them off. Like, I'm sorry, your kid's not going to make the NFL in 3rd grade. Like, it's not done. It's never been done. It's never going to be done, right? So, like, take responsibility and take ownership. Is like, all right, my kid is hurt. My kid potentially has concussion. Let me take the steps necessary to make sure he or she is A-okay, whether that's soccer, volleyball, whatever the case may be. And then just educating the family members as far as their resources. And that's the tough thing. We have these communities that don't have any resources within that zip code. We have communities that have all the resources within that zip code. So there's going to be some discrepancy there, but some way, somehow we have to kind of bridge that gap and find a way to provide the care necessary. And even if that's one provider having to wear many, many hats, which you see a lot in rural populations.
So it's funny that you just said wearing many hats, because that leads into the next question that I think is interesting. We talked a bunch about education today, as well as sort of policy enactment and things. And I'm curious if either of you have any comments on sort of engineering approaches. Are there other sorts of things that could be happening, like helmet redesign, or the sort of other environmental changes to the game that might be important as well?
Yeah, I think that's a great question. And that's a direction that a lot of people want to go, because it'd be so nice if you could like have the magic helmet that prevents all future concussions. And I'm not saying there's no potential for improvement here. But I think in terms of the tools in our toolkit, the amount of improvement we're going to get from, improving helmet technology is perhaps not going to be as much as some of these other ideas, whether it's building trust with your clinician and, being more willing to disclose an injury that happens, unfortunately, whether it's, taking some of these primary prevention measures, whether it's like prehab exercises, whether it's, this policy approach to just reducing any unnecessary contact in practice, getting coaches on board with safety messaging. I really think that a lot of these kind of upper level environmental factors beyond safety equipment, unfortunately, are going to be the bigger piece of the pie in solving this problem to the extent that it's possible.
Yeah, and just to piggyback on that, I agree with everything Christine said, and I think it's also important to acknowledge that the return to play progression. It's not just, oh, my kid's asymptomatic here for 5 days to a week or whatever, get back out there and play. Like, we have to put these kids or the athlete through, not necessarily a battery of tests, but introduce football or volleyball or soccer focused drills and progress them to see how much they can take, sub-max threshold to max threshold to plyometrics, things of that nature. Like, you have to take steps to clear them, just like a knee surgery. And I think we lose sight of that. It's like, okay, you're able to go back to school, cool, you can play. Well, we don't see somebody having a total knee. All right, let's go ahead and do a drop box jump off of an 18-inch box. Like, you work up to that level, right? So that's what we need to kind of keep in mind when it comes to concussion rehab.
No, I love that. And thank you to those of you who shared various stories, about it didn't used to be that way in terms of sort of being told to get back on the field or even being yelled at for kind of being injured. Last question, I think, is in the sort of policy realm. There's some questions around rule changes in football and whether that could help with primary prevention. So things like more penalties for hits to the head or sort of reducing other kinds of potentially risky situations. I don't know, any last parting thoughts there in terms of whether there's any low-hanging fruit of how we can be preventing concussions?
Yeah, I mean, I think that is a great question. And my kind of blanket answer is these are all empirically testable questions, right? If there's a willingness to try, right, we can figure that out. And there have been a number of efforts where there have been rule changes in football, for example, that have been put into place, tested, and we know something about it. But there's been plenty more where they've been put into place, not tested, and we just hope. If there's one parting message of mine is I think hoping a policy works is not a policy solution. And in some cases we see inadvertent consequences. So we saw increased penalties. There was an increased or reinforcement of the penalty for targeting to the head. We saw more knee injuries as a result, right? Instead of going at the head, we went lower, we got more knee injuries. That's a trade-off. If that's a trade-off we're willing to make, that's great, but it is a trade-off, right? And so there are plenty of policy solutions that are options, but again, hoping a policy works is not a policy solution. So anything that gets tried should be tested.
Well, Christine, thank you. That really brings it around in a nice circle, I think, of the critical importance of having research and evaluation to guide our practice, but then also looking at our practice critically in that sort of never-ending cycle, and why it's so important for those of us in the research and evaluation realms to be partnering with public health practitioners and medical practitioners, clinicians, and so forth. Thank you to our audience for joining us. I'm sorry we couldn't get to all of your questions, but thank you so much to our speakers. This recording will be on the web if you want to share it or revisit it later. And we hope to see you all back in October for our next webinar on climate change and workplace injury. Thank you again for joining us.
Thank you all once again, David, especially you.